Hi everyone, my name is Dr. John Shia. Today we are going to look at the hypersensitivity. Hypersensitivity is an exaggerated immune response which is harmful to the host. It can be categorized into 4 types. Type 1, Type 2, and Type 3 are antibody-mediated, whereas Type 4 is cellular-mediated. The term allergy is often equated with hypersensitivity, but more accurately, it should be limited to IgE-mediated reaction as in type 1 hypersensitivity. So, what is type 1 hypersensitivity? Type 1 or immediate hypersensitivity is caused by common allergens such as pollens, animal dander, shellfish, peanuts, bee venom, penicillin, cephalosporin, and sometimes due to wearing of latex gloves. The term shellfish is something of a misnomer. Not all shellfish have shells, and none of them are in fact fish. Shellfish is more a general culinary term that breaks down into 3 different types: mollusk, such as mussels, cockles, and octopus; crustaceans such as crabs, shrimp, and lobsters; and echinoderm such as sea urchin. Initial exposure to these allergens triggers the formation of immunoglobulin E. Fc portion of IgE then binds firmly to the surface receptor of most mast cells and basophils in pairs. This process is known as sensitization. Re-exposure to the same antigen results in cross-linking of IgEs, leading to degranulation of histamine. Symptoms such as wheals and flare and itchiness appear rapidly, and 6 hours later, asthma, hives, angioedema at the lips, and eczema may develop. Clinical manifestation is very much dependent on 2 factors: the route of entry of an allergen and the location of IgE-bearing mast cells. Individuals exposed to pollens in the air get hay fever or allergic rhinitis, whereas those who ingested allergens in food get diarrhea. People who responded with urticaria have the IgE-bearing mast cells in the skin, while those who responded with rhinitis having them in the nose. In severe cases, it may even go into systemic anaphylaxis involving multiple systems, which accounts for 70% death cases. Anaphylaxis is a serious allergic reaction that is rapid in onset and may cause death. It typically causes more than one of the following symptoms: an itchy rash, throat or tongue swelling, shortness of breath, vomiting, lightheadedness, and low blood pressure. These symptoms typically come on over minutes to hours. We will now look at some examples of type 1 hypersensitivity. Atopic disorders such as hay fever, asthma, eczema, and urticaria are immediate hypersensitivity reactions. These disorders exhibit a strong familial predisposition and are associated with elevated IgE level. It is observed that antigen uptake by antigen-presenting cells is enhanced in atopic patients, and their target tissues for allergen contain a large number of T helper cells. This increases production of interleukin-4, resulting in accelerated class switch from IgM to IgE. In an allergic individual, exaggerated class switching from IgM into IgE due to overproduction of interleukin-4 by T helper 2 cells causes more mast cells being sensitized, thus increases the amount of mediators released. In contrast, a non-allergic individual will respond to the same antigen by IgG production, and there are no IgG receptor on mast cells and basophils. Next, we will move on to drug hypersensitivity. Certain drugs will induce type 1 hypersensitivity, and it is usually not the intact drug that induces antibody formation. Rather, its metabolic product, which acts as a heptan, does so. In this case, the drug metabolite binds to the red blood cell. The whole complex triggers the production of IgEs. IgEs then sensitize the adjacent mast cells. It then gives rise to type 1 hypersensitivity upon second exposure to the same drug, with abundant histamines being released. When a drug is being injected into a sensitized patient, a large amount of mediators will be released as a result of massive cross-bridge of antigen and mast cells. Fatal systemic anaphylaxis results. Thus, drug desensitization is a method of safely administering a medication to a drug-sensitized patient. This procedure temporarily allows the allergic patient to take the medication by tricking the immune system into accepting it. Drug desensitization is only indicated in situations where there is no other acceptable alternative drugs that can be substituted. For instance, penicillin is the treatment of choice for syphilis during pregnancy, as no proven alternative is available. Penicillin is given at gradually increasing dose at 15-minute interval until the final dose of 2.4 million IU is achieved. This procedure involves the administration of a very small amount of penicillin at 15-minute intervals. Penicillin IgE complexes are formed on a small scale, and there is no enough mediator released to produce a major allergic reaction. This permits the administration of penicillin to a hypersensitive person. Next, I would like to show you how drug desensitization is carried out at Brigham and Women's Hospital in the United States.
So the definition of drug desensitization is essentially a method in which we can reintroduce the drug that the patient has become allergic to that patient safely. So the key word in desensitization is to have a very allergic patient who may have presented an initial reaction to that medication, like hives, like flushing, like itching, sometimes more severe. We know that a patient needs desensitization when after a reaction we do a skin testing and we observe a positive response to that skin testing. And skin testing will be just putting a drop in their arm and then proceeding to see if they have like a what we call a will and flare reaction. So if a patient develops that reaction, it means that they are sensitized to the medication, and every time that the patient will be exposed to the drug, they actually would react if not desensitized. There was an unmet need about patients who presented reactions to their first-line therapy, patients who had cancer and reacted to their chemotherapy, patients who had severe infections and reacted to their antibiotics, patients who had connective tissue disorders, rheumatoid arthritis, Crohn's disease, and others, and reacted to their wonderful medications. And we started a program to allow those patients to be back on their first-line therapies. We have desensitized patients to all kinds of chemotherapy medications, but also to antibiotics and also to what we call monoclonal antibodies and small molecules. the process by which this is occurring is we divided the total dose of the medication in different bags at different solutions, one in 100 solution, one in 10 solution, and the straight solution. And we approach the delivery of the medication very, very slowly. So every step of the desensitization protocol, which typically has 3 bags and 12 steps, or 4 bags and 16 steps, at each step the patient receives the doubling of the dose the step before. And by that, the immune system is tricked and inhibited to react. And so patients can very safely receive in about 5 to 6 hours the whole amount of medication that they need without having the symptoms of allergy or anaphylaxis. Patients might react during the desensitization protocol, and the beauty of that is we stop the infusion, treat the patient, and continue. So that has allowed patients with cancer actually to continue on their cancer medication, to complete their treatment plan, and actually to have increased lifespans. We have also done that for monoclonal antibodies in patients with rheumatoid arthritis, with Crohn's disease, and other diseases that require monoclonal antibodies, and the patients have continued to have an excellent quality of life because they are on their first therapy. We also have worked with cystic fibrosis patients who are very prone to infections and who are also very prone to allergic reactions because they have had exposure to many antibiotics. And the more people are exposed to a medication, the more the likelihood that they become allergic. Drug desensitizations are available to everybody who has a allergic reaction. It has been said in the past that somebody who had a very severe reaction should abandon that medication, should not be taking that medication again. And that we have actually broken that paradigm. In fact, patients who are extremely allergic, who have had anaphylactic reactions to their medication, can be very safely desensitized.
Chronic desensitization involves a long-term weekly administration of allergen to a hypersensitive person. This stimulates the production of IgA and IgE against the allergen instead of IgE. IgA-IgG neutralizes the allergens and prevents them from cross-linking with membrane-bound IgEs on mast cells, thus preventing degranulation of histamine. Type 2 or cytotoxic hypersensitivity happens when antibody directed at the cell membrane antigens activates complement system. C3b cleaves C5 into C5a and C5b. C5b, C6, C7, C8, and 9 then form membrane attack complex and lyses the cell. In addition, C3b also makes the antibody cell complex more palatable to be ingested by macrophages. Type 2 hypersensitivity could be induced by drugs or microbes. For example, penicillin attaches to the surface protein of red blood cell and initiate IgG formation. These autoantibodies then interact with red blood cell surface, resulting in hemolysis. Quinine, an antimalarial, on the other hand, attaches to the platelets and induces autoantibody that lyses the platelets, resulting in thrombocytopenia. This leads to bleeding tendency. Hydralazine, an antihypertensive, modifies host tissue and induces autoantibody against cell DNA. As a result, SLE-like manifestations occur. Whereas for microbe-induced type 2 hypersensitivity, Mycoplasma pneumonia infection can induce antibody that cross-react with red cell antigen, resulting in hemolytic anemia. In rheumatic fever, antibody against group A streptococci cross-react with cardiac myosin. In Goodpasture syndrome, antibody binds to the glomerular basement membrane of the kidney and lungs. This antibody basement membrane complex activates complement system and produces C5a, which is a chemotactic factor. C5a then attracts neutrophils to the site and they release proteases which damage the cell. So far so good. Following. Next, we will move on to type 3 immune complex hypersensitivity. Type 3 hypersensitivity occurs when antigen-antibody complexes induce an inflammatory response in tissues. In this case, free antigens are involved as opposed to the cell surface antigen as in type 2 hypersensitivity. Normally, immune complexes are promptly removed by macrophage system, but occasionally they persist and being deposited in tissues, resulting in several disorders. These immune complexes activate the complement system, mainly C3a and C5a. Neutrophils are then attracted to the site. Inflammation and tissue injury occur. For example, arthritis in joints, nephritis in kidneys, and vasculitis in blood vessels. Two typical type 3 hypersensitivity reactions are the Arthur's reaction and serum sickness. Arthur's reaction involves the in situ formation of antigen-antibody complexes after the intradermal injection of an antigen in a sensitized individual. Arthur's manifests as local vasculitis due to deposition of IgG antigen complexes in dermal blood vessels. Activation of complement primarily results in cleavage of soluble complement proteins forming C5a and C3a. This activates recruitment of polymorphonuclear cells and local mast cell degranulation, resulting in inflammatory response. Further aggregation of immune complex-related processes induce a local fibrinoid necrosis with ischemia aggravating thrombosis in the tissue vessel walls. The end result is a localized area of redness and induration that typically lasts a day or so. Arthur's reaction is rarely reported after vaccination, but it can occur after tetanus toxoid-containing or diphtheria toxoid-containing vaccine injection. Arthur's reaction is characterized by severe pain, swelling, induration, edema, hemorrhage, and occasionally necrosis. These symptoms and signs usually appear 4 to 12 hours after vaccination. Serum sickness is a systemic inflammatory response caused by deposition of immune complexes in many areas of the body. Typical signs are fever, urticaria, arthralgia, lymphadenopathy, splenomegaly, and eosinophilia. This happens a few days to 2 weeks after injection of the foreign serum or drug. For example, anti-thymocyte globulin in horse serum is used as immunosuppressive agent in transplant patients, causes serum sickness. Next is a disease condition called glomerulonephritis. Beta hemolytic streptococcal infection causes streptococcal antibody complexes deposited on glomeruli. It fixes complement and attracts neutrophils, which starts the inflammatory process. Other diseases that cause lumpy deposits include infective endocarditis, serum sickness, hepatitis B, and dengue hemorrhagic fever. IgA neuropathy is characterized by deposition of IgA on the glomerulus. Another typical example would be rheumatoid arthritis, a chronic inflammatory autoimmune disease of the joints, seen commonly in young women at the age of 30 to 50 years old. The synovial fluid contains rheumatoid factor, that is autoantibody, that binds to the Fc region of a normal IgG, forming an immune complex. These complexes are then deposited on the synovial membranes, activating the complement system. C5a then attracts pro-inflammatory cytokines such as tumor necrosis factor, interleukin-1, interleukin-8, and neutrophils, causing inflammation. Next is systemic lupus erythematosus. Systemic erythematosus is a chronic inflammatory autoimmune disease that affects several organs, especially the skin of the face, the joints, and the kidneys. Antibodies are formed against nuclear DNA fragments. The immune complexes activate complement and C5a is produced, which attracts neutrophils that releases enzymes, thereby damaging tissues. This diagram shows the clinical signs of SLE, including mouth ulcers, pleuritis, hair loss, butterfly rash on the skin, endocarditis, anemia, muscle and joint pain. We will now move on to type 4, delayed hypersensitivity. Delayed hypersensitivity is due to sensitized T helper cells and not antibodies. In contact hypersensitivity caused by poison ivy, the response is delayed, that is, it starts hours or days after initial contact and often lasts for 7 to 10 days. Upon second contact, the pruritic vesicular skin rash is caused by CD8 cytotoxic T cells that attack the skin cells, displaying the plant oil as foreign antigen. Clinical signs include dermatitis and vesicular skin rash. Avoidance of the allergen or the plant will prevent recurrence. Next is tuberculin type hypersensitivity. When the patient previously exposed to Mycobacterium tuberculosis is injected with a small amount of tuberculin intradermally, there is a lethal reaction in the first few hours. Gradually, however, in duration of about 5 to 15 meters in diameter, with redness develop. It peaks in 48 to 72 hours. A positive skin test indicates that the person has been infected with Mycobacterium tuberculosis, but it does not confirm the current disease status. The induration of greater than 15 mm in diameter is considered positive in a person with no known risk factor for TB. However, in HIV positive patients, induration of greater than 5 mm in diameter is considered positive for tuberculosis. Last but not least, anaphylactoid reaction or pseudoanaphylaxis is a non-immunological anaphylaxis. It does not involve an allergic reaction. It occurs through direct mast cell degranulation or as a result of direct complement activation. Examples of drugs as in adverse drug reaction: radio-opaque contrast media, NSAIDs, aspirin, opiates, and thiamine. With this, I thank you for your attention.